Thank you and welcome to the last session that we have today, which is our Pfizer sponsored session. And with me joining today is Dr. Emily Riehm Meier. I'd like to introduce Dr. Meier as a board certified pediatric hematologist oncologist who provided clinical care for infants, children, and adolescents with sickle cell disease and other non-malignant hematological diseases for 20 years before Global Blood Therapeutics as a senior medical director in March 2022. Now, with the acquisition of GBT by Pfizer, she's now a medical director of sickle cell in the Global Medical Affairs and has been seeing patients as a volunteer on a volunteer basis 1 day a month at Children's Hospital of Michigan since September 2023. Without taking much more time, I'd like to take this moment to have Dr. Meier share a slide and present to us. Dr. Meier, thank you.
Thank you so much for that introduction. And hello, everyone. I understand I'm the last session of the day, so so we'll hopefully will be worth your time here as you wrap up the Congress. Lanre, can you see my slides okay?
Yes.
Are they projecting okay? Okay, great, perfect. Well, on behalf of Pfizer, I just want to thank the organizers for the opportunity to talk with you today. And what we're going to talk about today is a project that we've been working on for about 2 years in developing a treatment decision-making tool for sickle cell disease management. And we have called it the Manage, Monitor, and Realize Framework, or the MMR, which as a pediatric hematologist, I'm still getting used to saying, since that's a very commonly administered vaccine, the MMR in children. So that's what I'm going to talk to you today about. So like I said, this is the Manage, Monitor, and Realize framework. And what we did at Pfizer is we convened a group of sickle cell experts from around the world, including North and South America, Africa, Europe, the Gulf Coast countries, and India. And together, these sickle cell experts, they also had specific expertise and interest in the different organs that are most impacted by sickle cell disease. So things like the brain, the kidneys, the heart and lungs. And we developed this this framework that includes 3 pillars. So the manage pillar mainly looks at laboratory markers of the disease, so hemoglobin levels, markers of hemolysis like reticulocyte count, but also takes into account acute complications like vaso-occlusive pain crises and acute chest syndrome. The monitor pillar is looking at different organs and ways that, in children at least, can we prevent organ damage, and for adults living with sickle cell disease, can we prevent progression of organ damage. And then the realize pillar is meant to focus on the patient and the individual living with sickle cell disease and their life goals. And we really wanted to model a shared decision-making kind of treatment decision framework, highlighting the fact that the patient and the person who's impacted by sickle cell disease, their voice is really important. And so all 3 of these pillars have equal weight. So one is not more important than the other. And as this was being developed, the expert HCPs really felt strongly about getting the patient input, not only people living with sickle cell disease, but also caregivers of people living with sickle cell disease and advocates working in the space. So that's what we're going to spend most of the time today focused on. So as I think most people know, that the treatment landscape for people with sickle cell disease has really expanded over the last few years, but we don't have great decision-making tools to understand which treatment fits which patient in which situation the best. And that unmet need really was highlighted, I think, and that's why we at Pfizer chose to focus on this. And again, we really wanted to emphasize the shared decision-making model. And so, as I said, the global sickle cell experts collaborated, and we had a series of advisory boards, and they also filled out online surveys, because I'm not going to get into the granularity of this, but we did include different targets for each one of the markers in each pillar, that if patients aren't meeting those targets, then perhaps a decision needs to be made about either adding therapies or switching therapies. And we wanted to make sure that people from around the world were represented when we developed this, so that it was relevant regardless of where individuals living with sickle cell disease were located. One of the key things for the MMR framework is not only to assess how the different lab values are looking, what the organs are doing, but also the way that the realized pillar and how patients' health-related quality of life are impacted. And if the treatment goals are met in all three pillars, then what the advisors recommended is that depending on how the patient's sickle cell genotype and other factors, then they could come back to clinic to be reassessed every 3 to 6 months. However, if those treatment goals are not being met in all three pillars, then they likely require more close follow-up and should come back every in 1 to 3 months, depending on what's happening. So just to get a little bit more in detail about what's included in each one of the pillars, is for the managed pillar, like I said, this is focused on laboratory parameters like your complete blood count, markers of hemolysis, but then also looking at vaso-occlusive crises. And it's important to note that this is the way the pillars were initially presented to the patient and advocates and caregivers when we sought their input. So you'll see how it kind of morphs over time. Also acute chest syndrome, looking at transfusion burden, and then again, risk of infections and vaccine status or the need for prophylactic antibiotics. For the monitor pillar, like I mentioned before, we're looking at different organs that can be impacted by sickle cell disease. So just to highlight a couple, the kidneys, as you know, are commonly impacted, especially as patients age. And so looking at the albumin creatinine ratio and the glomerular filtration rate for individuals who are over 18 years of age. For cardiovascular, looking at the echocardiogram, trying to screen for pulmonary hypertension, and then also in people who have iron overload, looking at perhaps cardiac MRI or liver MRI. And then with the realized pillar, this is the one that is focused mostly on the individual living with sickle cell disease's goals. So asking them about short, mid, and long-term goals, perhaps doing some assessments of health-related quality of life, like pain or fatigue, doing screenings for anxiety and depression. And then when we talk about transition, it's not only the transition from pediatric to adult care, but also doing everything we can to prevent the transition from an acute pain phenotype to that chronic pain phenotype that is so much more challenging to treat. And then taking into account the entire life cycle of someone, and so talking to them about fertility goals and family planning and how a treatment may impact that. So if we dig in with more detail into how we interacted with the patients and caregivers and advocates, again, the HCPs are the ones who really drove this, and they really wanted to emphasize the role of shared decision making and really get a better understanding of the care gaps from different regions of the world. And we wanted to make sure that the patients felt empowered to make informed choices, which hopefully would improve patient satisfaction, adherence to the treatment, and health outcomes overall, which I think is the main goal of this. So what we did was we convened a group of 6 advisors from around the world, and we were able to have advisors from the US, from the United Kingdom, from Italy, Saudi Arabia, and Nigeria. And they were chosen based on their advocacy work as well as their lived experience with sickle cell disease. Before we had the advisory board, we asked them to complete a 20-minute online survey that allowed them to pick between two different treatment outcomes as to which they would prefer. So if you were taking a treatment, would you want the treatment to reduce the amount of pain or allow you to make short-term goals? And we'll go through some of those results. And then we use the results of that survey as the basis for our discussion with the advisors. Thankfully, the PAG advisors provided feedback on all three pillars, not just the realize pillar. And they also talked about different discrepancies and missing framework components, which really helped strengthen the overall framework. So this is just some demographics of the patient advocates who participated. We had 4 males and 2 females. All of them were over 18 years of age. And then you can see that these participants had experienced multiple different types of treatments for sickle cell disease. And they could choose multiples of these, right? So these numbers add up to more than 6. But you can see that most of them had received a red cell transfusion. Most of them had been prescribed hydroxyurea at one point or another in their disease journey. And then as far as curative treatments, several of them had explored gene therapy and bone marrow transplant, but there were 2 who had not considered curative therapy. So these are the results of the relative importance of treatment outcomes that I alluded to before, and you can see that on the far left in the blue box, reducing frequency of pain episodes was what was deemed most important as a treatment outcome, and that was considered about 2.5 times more important than avoiding chronic pain by the advisors, and almost 6 times as important as not worrying about sickness. And then over here in the red bars are the things that the advisors said weren't really important to them when they were thinking about how treatment might impact their lives. And so ability to run errands, ability to do housework, and then the ability to make midterm plans. And we're going to dig into this a little bit more deeply in the upcoming slides. So each one of these dots is a response from each advisor. And a couple of the things that I'd like to highlight is you can see that the survey questions around pain, like this is reducing frequency of pain episodes, the impact of pain on usual activities, avoiding chronic pain, those dots are all pretty tightly grouped, right? So we had a lot of agreement among our advisors about the importance of those treatment outcomes. But then you can, if you go down here a little bit, you can see that fertility and the ability to make short-term plans, there certainly was much more spread among the advisors. And so we wanted to understand more about that. And because like I said, we had these results before the advisory board, so we were able to probe on these items more to get a better understanding of why there may be a variable response. So again, the items here in the green box are the ones that had the most agreement. So ability to do relaxing activities had a negative score. So it wasn't really one of those treatment outcomes that people felt were really important. But again, the reduction of pain was super important. But then the ability to make short-term plans and fertility were the 2 that had the least amount of agreement. So we probed on that, like I said. So with the making plans piece, what the advisors taught me and told us was that people with sickle cell disease often struggle to make short-term plans because they can't predict when the pain's going to happen, right? Like if we were able to do that, that I think would make everyone's life much more smooth and would make the impact that this disease has on people's health-related quality of life, I think, much less. Long-term plans felt more achievable to our advisors because you can anticipate challenges, and because there's a longer length of time, you can kind of adjust and pivot depending on what happens in the short term. And in the advisor's experience, short and long-term plans aren't often discussed during clinic visits. And then with regards to fertility, it was definitely a very personal decision, and it depended on your age and your stage in your life. So we had some advisors who had already had children, and so fertility was less important to them. But there was a younger advisor who had had a bone marrow transplant and valued fertility very highly. And then we had a couple advisors who'd actually experienced a pregnancy, and that pregnancy had a negative impact on their sickle cell disease. So they were reconsidering whether or not they wanted to have a second child after that first one. Oh, that slide didn't come through very well. Okay, so the other things that came through in the advisory board is that every advisor had had the experience of needing to teach one of their doctors about sickle cell disease, especially in the emergency department. And I doubt it will surprise anyone in the audience that many of these clinicians were resistant to receiving education from their patients. And so, what they really needed and asked for was phrases to help inform their clinicians about aspects of their disease that could help facilitate the discussions that happen, not only in clinic, but in the emergency department. And this actually surprised me a bit, is that um, patients, they're not getting very good education about curative therapies when they're in sickle cell clinic, and they did a lot of online research themselves. So that was kind of a theme for the discussion as well. So this is how our patient advocate and caregiver advisors helped um, deepen and strengthen the framework. So the items here that are in the shaded boxes are what the patient and advocates recommended be added. So they really wanted a specific call out to platelets um, under the complete blood count parameter. They wanted to add VOCs managed at home, because I think, as we all know, that's where the majority of pain is managed by individuals living with sickle cell disease. And then they actually brought up treatment adherence, because they said if you're not taking the treatment regularly, then it's hard to know if it's truly impacting many of the targets that are in the framework. As far as the monitor pillar, they wanted to add priapism, splenic complications, sleep apnea, and insomnia, which we ultimately did put in under the pulmonary parameter. And then as far as bedwetting or nocturnal enuresis, ultimately we couldn't come to a consensus among the HCPs about including that one. So that one is not included in the framework. And then they added a lot of depth to the realized pillar. So looking at social determinants of health, patient health education levels, so health literacy, nutrition status, sexual dysfunction, family planning, and how different treatments may impact that in the future, and then suicidal ideation. So this is just going to walk through how our patient advocate caregivers added to the decision-making algorithm. So this is the way it looked before we had these ad boards. Afterwards, we added at the very top prompt diagnosis, because we want this to be globally relevant. We had some advisors from places where sickle cell disease is not screened for in the newborn period, and they had stories of friends and colleagues who hadn't been diagnosed till their 20s. And so they really wanted to put an emphasis on the importance of prompt diagnosis. The other thing they asked for is teaching people how to use the framework. Like I said, we haven't gotten into a lot of the granularity, but it's pretty involved in the different treatment targets. And so they felt like videos and sessions, not only for providers, but also for patients, to understand how to use the framework, and as well as for community physicians and the emergency department, and make sure that they were also accessible to patients who maybe had lower literacy levels than others. And then the other thing that they continued to emphasize was the fact that the realized pillar is very important, and it's often overlooked. So even though in this framework, the realized pillar is given the same amount of weight as manage and monitor, in the office, the patient's lived experience is that it's not given the same amount of time as maybe discussing lab values or screening tests for organ function. And so again, they were very engaged. They offered tons of valuable insights. And the HCPs, when we took these contributions back to them, they were so thankful. They really were grateful about the things that were not included in the original framework that now are, because of the feedback that we got. And they're practical for both HCPs and patients. And so these are the HCP advisors are listed on the left, and then our patient advocate caregiver advisors are listed on the right. And I am presenting this work on their behalf, and I just am really grateful for their participation and their open and honest feedback on this framework, so that hopefully once we get it published and it's out into a more widespread kind of forum, like a journal or something, that it will be used and can help make treatment decisions for patients. So I'd be happy to answer questions, comments, concerns. I really, again, appreciate the opportunity to present.
Thank you so much, Dr. Meier, for your insightful presentation. Let's appreciate Dr. Meier with a lot of reactions. It's amazing to see the work that, both clinician and patient community are able to, work together and do together. Thank you so much. Are there questions for Dr. Meier? I don't see any in the chat. Yeah, I see one just dropped in the Q&A box. And the question is Pfizer open with collaborating with patient advocates or community-focused initiatives that not only raise awareness and improve education, but also explore pathways for making essential sickle cell medications more affordable and accessible in low resource settings? Is Pfizer open to that? Thank you.
Yes, definitely. We, I think everyone probably knows that the last year and a half at Pfizer has been a bit bumpy. And we know that when the news came out about the voxelotor withdrawal I guess it's been about a year ago, it came as a big surprise to the community. So we have certainly made a concerted effort to engage with patients and advocates more and be as transparent as we can about where things are. And certainly we welcome their input because we know that where most of the people living with sickle cell disease are physically located is not necessarily where the newest treatments are available. So yeah, we're definitely open to that feedback. We have I think many people probably know Mariah Kelly, whose whole goal and whole role at Pfizer is engaging with patients and advocates from around the world. Yeah.
Thank you, Dr. Meier. I also have one or two questions for you. How do you plan to increase awareness about this framework among healthcare providers and people living with sickle cell? Because we know that this framework could really be a game changer in many settings. How do you intend to raise awareness around this framework? Thank you.
Yeah, thank you for that question. Yeah, so as I alluded to, we have two publications that will be submitted in the upcoming weeks to months. One about the overall framework, and that one's authored by the HCPs, the healthcare providers who were involved. And then we're going to have a separate one that basically covers how the patient advocates and caregivers strengthened it and give more granularity around the survey results. The other thing we're doing is that any attendees who will be at ASH in December, we're actually having an industry forum that will include 4 panelists. So 2 HCP panelists, Drs. Wally Smith and Melanie Fields, and 2 patient advocates, Mr. Kevin Wake and Miss Mariah Scott. And they'll be part of a panel, and it'll be less didactic than what this presentation was, and more interactive. So then audience attendees can ask questions of the panelists and get a better understanding of that. So we're hoping that through all of these different ways that we're getting the word out, so people will use it.
I just also want to mention that organizations such as GANSIT could also play a role in helping to disseminate the framework, because we work with clinicians, we work with patient communities. We have about 125 patient organizations across 35 countries. And I think that sort of resources could also be leveraged as well. Thank you for that.
Yes.
Another question I have for you, Dr. Meier, is were there any recommendations by either the healthcare providers or the patient advocates involved in this framework as to how to consolidate sickle cell care so that people who are affected do not have to go to multiple different subspecialists to get all of the recommended screening tests. Is there any way for subspecialists to come to sickle cell disease clinic to perform the screening? Thank you.
Yeah. So I'm located in the US, which is where I practice, right? So in the US, everything's about insurance coverage and what the insurers will cover. But if you look at this list of different organs that need to be monitored, I mean, it's exhausting, and it could be consume your entire week, right? Month, going to all these different doctor's appointments. So I know that there have been different attempts in different clinics, and it's largely based on the payer, because we certainly don't want patients, and again, I'm speaking from a US perspective, not a global perspective, but we don't want patients to get bills for things because their insurer refuses to cover it. But where I am now, in Detroit, Dr. Alex Glaros, who's the director of the Peds Sickle Cell Clinic in Detroit, he's successfully gotten a TCD machine in the clinic. And so when I see children who are in need of transcranial Doppler screenings, they can get that done before they even see me. So I have the results when I walk into the office, which is really remarkable. And Dr. Glaros is going to be presenting that work and the impact that that's had on improving TCD adherence at ASH as an oral abstract. I think it's on Monday of ASH. And so those kind of small efforts that really make a big difference to patients and families. Hopefully, as people hear about them, then they become scalable, and then people can learn from what Dr. Glaros has done in Detroit, and then take that to their office and talk to their radiologist and be like, hey, look, Detroit's doing this. Why can't we do this? And so I think it's that word of mouth and the patient advocacy voice that really is going to help until we can get comprehensive sickle cell centers that perhaps become true medical homes and encompass all of these subspecialties, all of these subspecialists who are focused on the impact that sickle cell disease can have on the different organs.
Thank you so much. I have another question in the Q&A box. As a Kenyan advocate, I'm looking forward to create impact if given a chance to reach more unknown diagnosed patients. How can we work with the patients through their voices using a boost with big organization? If I may answer that, Himo, I would say
Yes.
it's very important that you work with, your patient groups, right, in your own country. And even if you have interest in maybe supporting some of Pfizer or other industry-related work, I think, first aligning with the patient group in your own local area is very important. And then, making your interest area known, that you have interest. I'm sure when you see some of those, people with lived experience who are on the framework, maybe you are also wondering, and so, the same thing with the anonymous person that put a similar comment there. You might also wonder, how can I also be involved in such similar work? I think it's great, but I think it's also important that you align and work with your with the organizations in your country and let them understand this is the area that you would like to support work, like with Pfizer and other similar industry partners, to ensure that we have more patient partners participating in such initiatives, to also ensure that there are improved access, right, to medication and frameworks and guidelines to really improve patient outcome. I don't know if Dr. Emily have anything else to add to that.
No, I think your answer. I agree completely, Lanre. Yep.
Thank you so much. Teresa said, I wonder when my country will one day achieve what rest of the world have, yet if my lowest facility accessing is basic CBC. So accessing CBC is a challenge. So I think the previous session we just had was about advocacy and working together to drive advocacy, no matter where you live in the world. So I don't think governments just wake up and said, "Oh, I remember there's a disease called sickle cell." Or
Mhm.
policymakers wake up and say, "I remember there's a disease called thalassemia or hemophilia." It is advocates that advocate for change. And this is
Mhm.
why it's important that we are empowered, both as clinician advocates and patient advocates, to drive these changes at country level. So, Teresa, I'm not sure what country that is, but whatever the country is, if you work with your patient groups and your clinician groups, you can really drive meaningful changes to improve life outcomes for people
Mhm.
who are affected by your disease. So, I want to thank everyone. It is 1 minute after we're supposed to finish this session. So I would say, but if you have any other session, any other questions, you can always send them to us. We will send them to Dr. Meier. Now, next step is I would like to put up a quick survey. I'd like people to see the poll. I mean, to complete the poll for this session. If the team can pull up this survey, please. Please help us complete this poll. Um, how would you rate your experience of Dr. Meier's session? How knowledgeable and engaging is she? How helpful is the content presented? What did you like about this session? What would you like to see improved? And what future topics would you be interested in? If you can do that in 2 minutes, we really appreciate that. Thank you so much for joining us on this session. And we would then move to also showcasing the survey on clinical trials. I just wanted to mention that quickly before we go into our closing remarks. If that can also be shared on the screen. Thank you. Okay, thank you. So it's in the chat. So one of the major projects of the GANSIT, I have said that yesterday and I'm saying it again, is the we're looking at the barriers, you know, to sites, especially in low and medium income countries, and also in high resource countries. What barriers do sites have in participating in clinical trials? So we would like you to, if you're involved in clinical trials in your country and you are a clinician, we would like you to kindly complete the survey to help us get insights into what barriers, as Gansett is working on developing guidelines that will address and improve, access to more clinical trials anywhere in the world. Thank you so much, folks. Now, we are getting to the end of um, 2025 Congress, and I don't know about you, but I don't necessarily want today to end. I've been enjoying, today, the last 2 days, and being in the midst of everyone with all of the amazing sessions, speakers, and everybody. It's just been amazing experience. So, but all good things must end. So I'm gonna say, as the CEO and co-chair of the Congress Planning Working Group, it has been an honor to convene this exceptional gathering of the Third International Congress on Sickle Cell and other inherited blood disorders. And I would like to extend my heartfelt thanks to my co-chair, Dr. Len Valentino, from the National Bleeding Disorders Foundation in the US, and the other members of our Congress Planning Working Group. I'd like to extend my heartfelt thanks to every participant, our esteemed speakers, our moderators, our media lead, Maria. She's done an amazing job on social media promoting the Congress. I'd like to thank you. I'd like to thank Dr. Simon Bayi and Mr. Bodo Mukoli. These two individuals actually sponsored patients out of their own pocket to attend this summit. They saw and they believe in the importance of knowledge sharing. And so, using your own funds to sponsor patients to attend this conference blew my mind. And thank you so much. We appreciate you for this. And to our industry partners, without you, this third International Congress on Sickle Cell and Other Inheritable Blood Disorders would not be possible. Over these 2 days, we have advanced crucial conversations on policy, innovation, advocacy, lived experience, clinical practice, health equity, and so on and so forth. What we have achieved here reflects not only our expertise, but our shared commitment to improving the lives of individuals and families affected by these conditions across the world. So I'm going to urge you to say, let us continue this work together collaboratively with urgency, compassion, collaboration. And I want to thank you again. And I look forward to building on this momentum with all of you in the months ahead. And you will see on my screen that I have put on the screen what's going to happen in 2026. So Gansid is going to move, transition from virtual Congress to in-person Congress. So this Congress this year is our last virtual Congress. We decided to take the first 3 years to do the Congress virtually for us to better understand the terrain in order to move forward effectively. So our next Congress will be in India. And so we ask you to stay tuned for more details. If you are not currently receiving our newsletter, please subscribe. Go to our website, subscribe to our newsletter so you can receive more information, about whatever is going on at Gansid. But stay tuned, and we will see you in India in 2026. Thank you again for being part of our 2025 virtual Congress, and we look forward to continue to build momentum with you based on all we've learned and share together in the coming months. Thank you.